Paul is taller than I am. Thank you for the kind invitation, Paul, to be here at Aspetar. And before I start, I would like to congratulate Aspetar on your recent designation as an IOC Research Center. I was delighted to see this, and I think it is a very worthy distinction, and congratulations to all of you for your role in that. I would also like to acknowledge a co-author on the IOC consensus document who is here in the audience. Nama Constantini from Israel was one of the group that worked on this paper. So I'd like to spend the next while discussing this with you. And the overview will speak of, to start with, on the physiology and evolution of the concept of relative energy deficiency, review next health implications, followed by performance implications, and spend a little bit of time on the male athlete, because this is the main change that we are introducing, is the male athlete. And then finally introduce the REDS clinical assessment tool, or the REDS CAT, and the models for screening and return to play. So let's start off the first section looking at the evolution of the concept. And as we all know, in 1986, Barbara Drinkwater, USA, coined the phrase the female athlete triad. And it had three pillars, as we know, of eating disorders, amenorrhea, and osteoporosis. And at that time, it was fairly revolutionary and groundbreaking, this concept, and was met with some skepticism within the science, but also the science embraced the opportunity and the community to investigate and further develop the concept. The IOC itself had a position stand in 2005. And the main change to the concept came about in 2007 with the ACSM document on the female athlete triad. And the concept changed, as you know, to have, rather than eating disorders, optimal availability, energy availability on the one pillar, the menstrual changes on the second pillar, and then on the third corner, bone health. And the main change was really the concept of continuation over time, where the energy availability changed, the bone health changed, and the menstrual changes over time. And you can see with the arrows, there's the interconnectivity in this concept. So this was a fairly big change in the concept that occurred in 2007. But really the underlying principle of the female athlete triad is the concept of energy deficiency. That's the core base from which all of the changes described in that continuum are seen. The energy deficiency is a relative imbalance between the intake of energy versus the expenses of energy. And those expenses, of course, are what we all have of homeostasis. We all have the energy expenses of physical activity of daily living. But what varies in many people, of course, is sporting activity. How much energy is spent, dependent on their sport, but also dependent upon where in their periodization of their training, how much energy they're spending. So we know that energy availability is calculated as what the energy intake is minus the cost of energy exercise relative to fat-free mass. And if we look at healthy adults, a value of about 45 kilocalories per kilogram of fat-free mass per day equates energy balance for a normal functioning body. So how have things evolved since 2007? Well, we know since, and I've known for many years in my clinical practice, is that it does not only affect female. My clinical practice has a lot of swimmers, as you can well imagine, but I also work in the training center for Triathlon Canada, so I look after a lot of endurance male and female athletes. My center is also the home of the middle and long distance track and field for Canada. So I look after all of Canada's endurance athletes, male and female. And for many years when I was telling my men that they had the female athlete triad, they were a little skeptical when I was looking at them with that diagnosis. We do know that energy deficiency also can affect the male athlete. We do know also that it does not only affect someone who defines themselves as an athlete. The clinical entity of relative energy deficiency affects those who are physically active but may not themselves define themselves as an athlete. That may be a master swimmer, it may be a dancer, a performing artist, someone in the Cirque du Soleil or in a national ballet who don't consider themselves an athlete. They say they're a performer. And we do know also from the science that it is well beyond the three components of a triad. It's rather a syndrome resulting from relative energy deficiency that affects many aspects of both physiological and psychological function beyond the menstrual cycle and bone health. So while we're not really changing what has been defined, we're just repackaging it based on the knowledge. So because of this, the International Olympic Committee held a consensus meeting 1 year ago. We brought in experts from around the world to discuss the change in science since the original consensus was produced in 2005, to look at the science, to update our documentation, and to make some decisions going forward. This group, after much debate, much discussion, and shall we say a lot of anguish, decided that we would further the phrase female athlete triad and coin a new phrase called relative energy deficiency in sport. So to define it, as in our paper, the syndrome of relative energy deficiency refers to impaired physiological functioning caused by relative energy deficiency. It includes but not limited to metabolic rate, menstrual function, bone health, immunity, protein synthesis, and cardiovascular health. Let's move on to the second part. What are the health implications of relative energy deficiency in sport? So this is the conceptual model based on some original work of Nama Constantini here in the audience. And you can see that the core is the relative energy deficiency in sport. From the core emanates the different body systems that are affected. I'd like to in particular draw your attention to the psychological, because this is the one where there's a double arrow where energy deficiency can cause psychological changes, but also the corollary that psychological issues such as eating disorders or disordered eating can cause the energy deficiency. And we have put the original triad of bone, menstrual function, and energy deficiency to illustrate that this is not changing the concept, it's expanding the concept. So let's take a few and discuss in a bit more detail. In particular, menstrual dysfunction, the health consequences. There's a question of long-term fertility issues. We all know of the extensive literature on functional hypothalamic amenorrhea. And we do know for some women that the emotional impact of amenorrhea can be significant. When we look at bone health, we know that the low estrogen can have an effect on bone health, but even despite the low estrogen, the low energy availability itself can have a negative impact on bone independent of the estrogen component. And we also know that low energy availability increases the risk of stress fractures. If we look at the cardiovascular system, there's evidence that low energy availability affects endothelial dysfunction as well as lipid metabolism. The endocrine system, reduction in glucose utilization, mobilization of fat stores, metabolic rate, and effects on growth hormone. Other health implications in the central nervous system, GI, renal system, and also for those athletes that are energy deficient because of restriction in dietary intake, there can be nutrient deficiencies, fatigue, and then the increased risk in infections relative to the relative to the nutrient deficiencies. The psychological and psychiatric changes that we see is stress, depression, disordered eating, and eating disorders. Let's move now on to performance. And in fact, we as physicians worry about our athlete health, and so we should. But I can tell you that most of my athletes don't really care too much whether they have their periods or not. In fact, many of them are quite happy not to have it. Many of them don't really care what their bone density is because they don't feel that. That doesn't really affect their performance, they think. But if I say, this can affect your performance, all of a sudden, I have their attention. That seems to make a difference to them. So let's discuss some of the performance implications. Again, the core center is the relative energy deficiency. And you can see around the edge that there are several potential performance enhancing, or pardon me, not enhancing, but performance detriments caused by the energy deficiency. In particular, can one have a favorite study? I don't know. I have a favorite study. I have many favorite studies, but this is one of my favorite studies. And it's not just because it's in swimming, but this is a wonderful study by Van Heest. And she took a group of swimmers, adolescent female swimmers, and in that group, that cohort of swimmers, a group of them were ovarian suppressed, and the other group had normal functioning ovaries. And these women were known to be energy deficient, the ovarian suppression group, and they underwent a 12-week training program. And the lower energy intake and energy availability obviously were in the ovarian suppressed group, and the metabolic hormones were also lower in the ovarian suppressed group. So at the end of the 12-week training, beforehand they had a time trial, and after the 12-week training, so both groups got the same training program. At the end of the 12 weeks, they had another time trial. So it's a strictly objective measurement of performance and looking at the training response and performance outcomes. So when we look at them, as you can see, the change in velocity from a 400-meter swim was 8.2% faster than the previous in the group of eumenorrhea with normal energy availability, and the ovarian suppressed were slower than their original time. So this is one study that I can show an athlete. Do you want to swim faster? Do you want to run faster? Then we must balance your energy intake. So we do know that viral illnesses can affect performance. I've worked with Olympic athletes. They train 15 years or more to get to the Olympic Games. And we have about a 9 to 11% illness rate during the Olympic Games, both summer and winter Olympic Games. That's a high, and the majority of these are respiratory tract infections. The second leading cause is often gastrointestinal infections. In aquatics alone, my injury surveillance studies, last 2013, it was gastrointestinal infections. These can be prevented. And we do know that nutrition and energy balance affects the ability of the immune system to fight this. We do know that low energy availability has an increased risk of a musculoskeletal injury. And we do know that certain behaviors related to disordered eating and eating disorders, subsequent to those behaviors, electrolyte disturbances, volume depletions, GI disturbances, these all can affect performance. And I've put down an acronym ADRV, and for those in the field that know, that's an anti-doping rule violation. For those athletes taking diuretics for weight loss with their disordered eating, of course, that can cause an anti-doping rule violation, which significantly affects your performance when you're not able to compete. So let's talk now about the male athlete. What is the science behind that? Well, a lot of our information comes from cyclists, and we do have evidence by Vogt et al. In 2005 that there's a reduced energy availability, quite low, in male cyclists. If we look at the jockey population as well, they experience outcomes from low energy availability. And if we look at hormone dysfunction in males, there's an interruption in the hormone function of men in certain sports. And if we look at reproductive function in male endurance athletes with high volumes, they have effects of reproductive dysfunction as well. If we look at eating disorders and disordered eating in this population, it's up to 50% of athletes, male athletes in the cycling population, have behaviors. Weight class 18%, gravitational 24%, team sports 5%, technical sports 4%. These numbers are lower than in female athletes, but still it exists, and for those physicians working with the male population, if we're not aware of this, we will be missing care that's needed. With looking at bone health in the male athlete, disordered eating and eating disorders are also associated with low bone mass. We also know that low energy availability alters the endocrine function, both directly and indirectly affecting bone health in males. But even in the absence of eating disorders and disorders eating, if we look at the endurance population, they also had a greater risk of low bone mineral density than controls. So irrespective of the disordered eating, they still can have low bone density. I'd like to take a few minutes now and introduce the models, the screening and the return to play models that we also developed. And I will just show you part of a publication that is currently in the British Journal of Sports Medicine, expecting to come out in the spring edition of the IOC Injury Prevention and Health Promotion. And it's part of our editorial response that will be published. And as well, in this publication, we are introducing something called the REDS CAT, Clinical Assessment Tool. I think most of us will have heard of the SCAT, the Sport Concussion Assessment Tool. So it's based very much on the Sport Concussion Assessment Tool. I know as a physician, being a Canadian physician, I look after a lot of ice hockey by default. It's in our blood. Our young men are born with skates on, I think. So I look after a lot of ice hockey players, and concussion is inherent to that. So in my clinic, I download the PDF from the British Journal of Sports Medicine, and I use it as a clinical tool with my athletes. So it is the hope of our group that also physicians working with this population will download the REDS CAT in a very similar format that will help guide the screening, evaluation, and return to play for these athletes. So it's based on the concept of red light, yellow light, and green light. So it's fairly simple, and one hopes that everyone can understand the concept. So it's a model for risk stratification and return to play decision making. So let's define what this is. So if we look at the high risk, no start, red light area, these are for the athletes that are seriously ill. So they're the ones with an active eating disorder. They're the ones that have serious either physical or psychological conditions related to their low energy availability, or they're involved in some extreme weight loss techniques that can affect their electrolyte balance, cardiovascular stability, and other life-threatening conditions. So this is the hopefully very small proportion of practice that sport participation would be dangerous. Now, I don't expect you to read all of this, it's in the paper, but just to define what it is, the yellow light are listing the syndrome and symptoms of the clinical entity that we hope to raise caution. So with the yellow light, if the athlete has any of these, it should be assigned to the clinician that they must stop and think and act to help this athlete earlier. I've been through them with you in terms of identifying the health implications. They're related to what we discussed as far as weight loss, body composition, menstrual cycle, bone health, stress fractures, other components that can be read. And of course, we hope that all our athletes are in the green light area where they have healthy eating habits, normal hormone metabolic function, healthy bone mineral density, and these are the ideal healthy athletes that we are not worried about. So those athletes that are in the red light, when we screen them, are denied participation in sport. And I think this is a very important concept because for years I would battle my synchronized swimming team because I would have someone who was fairly seriously ill and I had no paradigm with which to say they shouldn't play sport. Or, we did, but but it's much clearer now if we can show them a model. This athlete should receive some treatment, and we recommend the use of a treatment contract with these athletes to guide their care. The bulk of the athletes affected by this, we hope, will be in the yellow light region, where they can train with a supervised medical treatment plan. If they can compete, if they've been cleared, but only under medical supervision, we recommend regular reevaluation. And we've put a time frame of 1 to 3 months because we want people to know that this isn't an entity where we expect big changes in a week. You know, if you have someone with an ankle injury or a musculoskeletal injury, we can evaluate at a shorter time frame. But these hormonal changes take time. And so 1 to 3 months, depending on the clinical situation and the timing of the athlete's training and competition, the intervals can be set by the clinician based on their expertise on the athlete's situation. And I think what's key is that we expect the athlete to have regular compliance and show progress and improvement in their situation. And of course, obviously, the green light athlete we're very happy with, and they have full training competition with absolutely no stipulations on their sport functioning. So I think that model, I hope, is fairly simple to understand. We'll now go and speak at the next clinical scenario after the athlete has been receiving treatment and we're trying to rehabilitate them back to full play. Either they've been off for a sports injury or for relative energy deficiency. So this is modified from Creighton et al. 2010, the return to play model, where step 1 is looking at medical factors. So again, it's small and I don't expect you to read it, but we look at the criteria set by Creighton and then have added RED-specific material so that physicians can see what we're looking for. Step 2, as we know, is evaluation of the participation risk. So looking at the sport factors, such as what sport do they play, what level of competition. I mean, we're all familiar with Creighton's return to play model. So we have added RED's specific criteria to evaluate. And then the third and final step in the Creighton model is looking at other decision modifiers, such as timing in the season, pressure from the athlete, conflict of interest, fear of litigation, the non-sport related decision modifiers. And again, there's RED-specific components that we've highlighted for the clinician. So once the clinician has gone through this evaluation, we re-look at the original model and classify the athlete again, either in the high risk red light area, the yellow light area, or the green light zone. So the athletes in the moderate risk or yellow light, again, can compete once cleared with supervision and continue training as long as they follow the treatment plan. It's the same model, but we carry it on through and return to play. So what I'd like to do is use a case example to show you how this model works. And this is an example from 2011. This is our Norwegian athlete. And this has been in the media, so this is not information that should be private. And it's about this particular athlete. And this athlete, she is a cross-country skier in Norway. I imagine you don't have a lot of those here in Qatar. But she was an endurance athlete. And she was having difficulties with an eating disorder. So she was found to have relative energy deficiency. She had lost a significant amount of body weight, low body percent fat in her composition, and she was not allowed to compete. An athlete contract was developed where she had to increase her energy intake, body weight, and percent body fat. And again, it was in the media. This is big news when one of the Olympic stars is benched. Benched due to weight concerns was the headline in the newspaper in Norway. So then when she was through treatment, we looked at her. She was evaluated according to the Creighton model. And she had improved her body weight and percent body fat. She was responding to training, and she was improving after treatment. Looking at her sport modifiers, she had a strong supportive team. She was at the Olympic level, and of course we do know that the Olympic Games were coming up. And when we look at other factors, really there wasn't much else in her situation. It was in season and she was ready to go. So this was an athlete that was returned and given the green light, and you can see it's a significant period of time that has elapsed during her treatment. So in February 2012, she was returned to play, and in fact, she did medal in 2014 at the Sochi Olympic Games. So this is an example of an athlete that was caught fairly early, treated appropriately, and returned successfully to play. I do have other examples which I will not illustrate today in interest of time, where the athletes were not treated in a certain way and the problem has gone on for a longer period of time, and eventually the health consequences were significant. What I've added to the back is the end of the clinical assessment tool. There is an example of the athlete contract, a REDS athlete contract, that physicians can actually download, print, and have the athlete sign. Now it's difficult to read, I know, because it's small, but it is at the top. Whoever is, it's physician driven, but the components of the treatment team are listed there by name. And the requirements that the athlete meet, you tick off the box and you add in the blank of what's specific for that particular athlete. And then the time period, the athlete signs, and then the interval of time period and how they're monitored is signed at the bottom. So it's a fairly clear guideline to help clinicians in the sports medicine field with the treatment and management of REDS. I didn't go in today into details of the treatment of REDS. It is reviewed in the paper. It's also reviewed very nicely in the recent 2014 publication from the American College of Sports Medicine by the group of Aurelia Native et al. It's an excellent review of the science in terms of treatment of this syndrome. So I know I'm done a little early. I have a meeting at 9, and I know some of you also have a meeting, but I'd like to leave some time for discussion because it has a fairly a topic that may warrant some discussion and questions. Thank you for your attention.